Assalamu alaikum. Good evening, everyone. My name is Mohammed Aljuraysi. I'm R3 resident in King Khalid University Hospital. Today, inshallah, I will give you a brief introduction into CT chest imaging by reviewing anatomy. Also, show you common cases in daily practice. So, what I'm showing today is my approach in reviewing any CT chest. So, I always start looking at neck, lower cervical, then mediastinum, and I will divide it to the three parts to make it easier for you: upper, middle, and lower part. Then I comment on the lung parenchyma. Uh, Before I go to the thoracic cage, I always looking at the mediastinal lymph nodes and axillary lymph nodes. So let's start with the neck and lower cervical. We have multiple soft tissue structure, airway structure, vascular. So let's start with this butterfly structure and in the neck. This is the thyroid gland. This is the right lobe, and this is the left lobe. And we usually see the normal thyroid gland in this appearance. It's appear homogeneous enhancement, symmetrical in size, doesn't has any black dots called nodule. If we see this, we report it in we put it in the report and ask to do ultrasound for further evaluation to make sure there's nothing serious. Between thyroid gland, there is a well-defined round structure containing air called trachea, and it is traveling all the way down to this area called carina before bifurcation. Then it is divided to the right and left main bronchus. After that, it will divide to the upper and lower bronchus. So again, trachea, then carina at this level before bifurcation. This is divided to the right and left main bronchus. Also, we have vascular structure here. This is called left subclavian, and this one is the right subclavian. And we usually giving the contrast through one of them. And you can see here this contrast passing through the left subclavian. The left subclavian go down, forming left brachiocephalic, and the right subclavian here forming the right brachiocephalic, joined together forming superior vena cava. This is regarding neck and lower cervical. And lastly, we have vascular structure here passing lateral thyroid gland. This is the thyroid gland, and it's vascular structure passing laterally to the thyroid gland. So this is called jugular vein. This is the right one, and you can see here there's left one. So this is regarding the neck and lower cervical. We move on to the upper mediastinum, and you can see here there is three rounded vascular structure from right to the left. This is called brachiocephalic artery, left common carotid, left subclavian artery. All of them originate from the aortic arch. The organization also the origin should be looked carefully, because sometimes we have something called anatomical variant, and this is normal, but something extraordinary, and we should mention it in any report for future surgery to avoid any vascular injury. So brachiocephalic artery go up and giving two branches of two artery. One is anterior and one is posterior. The anterior one is the right common carotid. The posterior one is the right subclavian. So we move to the aortic arch. This is the aortic arch. It's divided to the two rounded structure. One is anterior, one is posterior. The anterior one is the ascending, as you know, and the posterior is the descending. At the level of the middle mediastinum, we have also another vascular structure. This is called pulmonary artery, and it's containing the main pulmonary trunk, right main, left main pulmonary artery. Then it's divided at this level to the upper and lower. We are looking for in pulmonary artery any thrombus formation to suggest PE. So be careful to assess the pulmonary trunk, pulmonary main and right main right pulmonary artery and left pulmonary artery for any thrombus formation. At this level, you can see here there is a posterior structure containing air anterior to the vertebra. This is the osseous. So this goes all the way down until the stomach. We move on to the lower part of the mediastinum, which involve the heart. So the heart, as you know, we have 4 chambers. Right ventricle, the most anterior one, left atrium, most posterior one. Also, we have the right heart border formed by right atrium and left heart border formed by left ventricle. Each chamber will contain a vascular structure. You can see here there's the pulmonary artery passing all the way and joining the right ventricle. Also, the aorta is passing, joining the left ventricle. What about superior vena cava and IVC? It is joining the right atrium here. Left atrium, it's involved containing the pulmonary vein. You see here, there is a superior pulmonary vein, and this one is the inferior pulmonary vein, joining the left atrium. So again, from up to down, we have thyroid gland, trachea, left and right subclavian. The left subclavian vein forming left brachiocephalic, and the right subclavian vein forming right brachiocephalic vein, joined together forming superior vena cava. And superior vena cava having vascular structure passing posteriorly called azygous vein. Superior vena cava joining the right atrium, as I said, also IPC. The upper mediastinum, again, containing 3 vascular structures from the right to the left brachiocephalic artery, left common carotid, left subclavian. All of them originate from the aortic arch. Sometimes left common carotid arising from the brachiocephalic artery. So this is called bovine arch. This is something called, again, anatomical variant. Sometimes has significance, sometimes it's not. Depend on the surrounding structure. And again, this is the aortic arch, ascending, descending, then the main pulmonary trunk, right and left pulmonary artery. Regarding the lung, the right lung containing 3 lobes and 2 fissure, major and minor. The left lung, only 2 lobes and only 1 fissure. I prefer to see it in the sagittal view. So this is the right lung containing upper, lower, and middle lobe, and the one passing horizontally, obliquely, this is the major fissure, and horizontally, this is the minor fissure. When we move to the left lung, there is only 1 fissure called the major fissure, and 2 lobes, upper and lower. In the right lung, we have middle lobe. In the left lung, we don't have middle lobe. We have lungula, and it's part of lower lobe. So regarding the lymph nodes, there is a lot of stations of lymph nodes in the mediastinum. It is not important for you at this time. We have para-aortic, we have retrotracheal, subcarinal, a lot of stations, but you should look carefully for enlarged lymph nodes. Sometimes it is due to TB, sometimes enlarged lymph nodes due to sarcoidosis, malignancy, and so on. What I want to tell you about lymph nodes, and it's important at your level to know the diameter of lymph node. It should not exceed 1 centimeter in the anterior posterior view. So this is the axillary region. So you can see there is multiple lymph nodes, and this is normal. Also on the right side. Regarding regarding the chest wall, we have clavicle, sternum, ribs, also thoracic spine. So let's start with the clavicle. The most anterior bone structure in the chest wall is the clavicle. So this is the proximal part, and this is the mid part, and this is the distal side. This is the right side, and this is one on the left side. Look carefully at the clavicle, especially in cases of trauma. We forget always to look at the clavicle. Also, we forget to see the sternum. So I prefer always to see the sternum in corona view. And first thing I look at in any trauma case is the sternum. So the sternum is containing three parts. This is the manubrium, this is the body, and last part is the xiphoid process. We move on to the rib. So first rib arising from first thoracic vertebra. As you know, this is the first thoracic vertebra, and this is the first rib. We have anterior part and posterior part in each rib. And in between, there is intercostal muscle. So this is the intercostal muscle in between the rib, and this is the first rib. Look carefully for any rib fracture in cases of trauma. Also, look for any lytic or sclerotic lesion in cases of malignancy. Also, one thing important in rib fracture, you should think about flail chest, and flail chest representing a two-part fracture in one rib and two or more contiguous rib. It is emergency. It's not like any rib fracture. So move on to the thoracic vertebra. So this is the thoracic vertebra, first thoracic vertebra. And the part of the vertebral thoracic vertebra, we have the body, and we have this pedicle. This is a lamina and spinous process, and in between, this is a transverse process. Always judge on any trauma, any fractures in the thoracic vertebra in two views, not only one view. You should look at the sagittal. Also, you choose coronal or axial, but sagittal is important view for any trauma. That's regarding the chest anatomy. There's no more information regarding it. There is already I explained everything regarding the muscle in the chest. It is always related to MSK rather than chest. We don't comment on the muscle on the chest wall or in the anterior or posterior aspect of the chest wall. So if you need a break before we go to common cases in the chest, daily practice, take your time. If anyone have any question regarding the anatomy, please write it down. Okay, press. Atresia osteotracheate fistula. Actually, I didn't put it in the presentation. I think it's anatomy rather than complicated cases like atresia or fistula. Yes, we need a contrast to see lymph nodes, but sometimes C- will show enlarged lymph nodes, but the characteristic of lymph nodes, if it's necrotic or not, we cannot without IV contrast. So we always would prefer to do IV contrast in cases of enlarged lymph nodes. Any question? Feel free to ask any question.
أرسلنا رابط تسجيل الحضور، أتمنى من الجميع يسجل فيه عشان نحسب الحضور.
Yes, the emergency and flail chest when you found two part fractures in one rib and two or more contiguous rib. So this is called flail chest. The physician will call you, tell you patient have flail chest already, but you should comment on in the report. Yes. Not not involved in the common cases, ground glass. But we have some cases contain ground glass. Ground glass could be anything. It's depending on the clinical history of the patient. Could be pulmonary hemorrhage, could be contusion, cases of trauma, could be related to the infection. Also, the consolidation could be related to TB, malignancy, could be related to pneumonia. So the clinical history is important in any CT chest. So the radiologist should involved in any discussion between teams, and the primary physician should give good information about the patient. Welcome. Should I move to common cases?
نقدر نكمل دكتور.
Okay, Doctor, could we please elaborate more about difference between lymph nodes and nodule again, please? Lymph nodes, it is in the soft tissue. Lung nodule, it is in the lung. So you can see there's tiny dots in the lung. So this is called lung nodule. But the lymph nodes within the soft tissue. So we have mediastinum here, multiple stations in the mediastinum. Also, we have axillary lymph nodes. We have intramammary lymph node as well, and we have subdiaphragmatic here. Sometimes we have lymph nodes. Also, we have retrocrural or behind the aorta as well. So we move on to the common cases in daily practice. So let's start with acute pulmonary embolism. So acute pulmonary embolism is partial or complete embolic occlusion of one or more pulmonary artery, and most likely due to thrombus, and the DVT is the most common cause. Patients usually come with acute chest pain, shortness of breath, tachycardia, some other presentation like atrial fibrillation, tachycardia, respiratory failure, depend on the degree or severity of the PE. So during daily practice, we do X-ray to exclude other causes rather than diagnose the PE, like pneumonia or pneumothorax. And remember that negative X-ray doesn't mean negative for PE. Sometimes we have some signs guide us to thinking about PE, like Fleschner sign, like Hampton hump, like Westermark. So let's start with the first X-ray. So this is a frontal X-ray of the chest. We do X-ray to exclude other causes like pneumonia or pneumothorax rather than direct diagnosis of PE. We have some signs may guide us to diagnose PE or thinking about PE like Fleschner. So again, this is a frontal X-ray of the chest, shows enlargement of both pulmonary artery, and this is compatible with Fleschner. In the second picture, you can see there is a peripheral wedge-shaped opacity in the right lower lobe, and this is compatible with Hampton hump, and is representing pulmonary infarction in cases of PE. Lastly, this is a frontal X-ray of the chest, shows area of clear of vessels compared to the contralateral side. The normal side, you can see here is a branching vessels passing from the central to the periphery. When you compare to the disease lung, there is area of clear of vessels and increasing lucency, and this is called Westermark. So this is regarding chest X-ray. Regarding the CT, it should be filling defect with one or more artery, it doesn't matter. So you can see here there's multiple filling defect bilaterally with surrounding contrast within the artery. So it is appear as Boloman sign. And the second picture, this is a CT axial at the level of the heart, shows enlargement of the right ventricle compared to the left ventricle. And this is called right heart strain. Again, not all the patients may have this sign. Lastly, this is a lung window of the CT chest, shows peripheral wedge shape consolidation at the right lower lobe, compatible with hum to hum in the X-ray, and is representing pulmonary infarction. So we move to the chest trauma. So the blunt injury is the second most common cause of death. Chest trauma due to sharing aortic injury, injury to the lung parenchyma, pleura, diaphragm, and skeletal axial skeleton also. Patient come with chest pain, shortness of breath, tachycardia, hypotension, also hypoxia. So what we found in the imaging, we may have pneumothorax, hemomediastinum, hemothorax, subcutaneous emphysema, lung contusion, and laceration representing as opacities in the lung. Also rib fracture, like I said, flail chest, maybe esophageal injury, tracheal, cardiac, and vascular injury. So this is a multiple CT trauma patient. So let's start with the first one. You can see there is extensive air within the mediastinum structure. This is called pneumomediastinum or extensive pneumomediastinum. Also, there is an air within subcutaneous soft tissue. So this is called subcutaneous emphysema. The second picture, there is air within the right lung pleura compatible with pneumothorax. And the third picture, there is a high density fluid. You can see there's a layering here, also a layer of high density at the base of the lung. This is representing a blood, and in between there is a low density fluid, and this is a free fluid. So this is a CT of the chest. Bone window shows multiple rib fracture. Also, there is a fluid, maybe free fluid or hemithorax. This is a picture of flail chest. You can see here there is a two-part rib fraction in one rib and two or more contiguous rib. This is important to mention in every report if there is any flail chest. Lastly, this is a lung window of the CT chest, shows peripheral ground glass, also consolidation in cases of trauma, could be represented laceration, could be represented contusion, could be related to aspiration, could be related to pulmonary hemorrhage. You should know the clinical scenario of the patient or history, the patient having hemoptysis or not, to suggest pulmonary hemorrhage. So after that, we move to aortic dissection. So aortic dissection occurs when blood enters the medial layer of the aorta through a penetrating ulcer or tear into the intima and goes all the way down to the median, forming something called false lumen. We should know which part of which part of the aorta is supplying the organs. Is it false lumen or true lumen? If the organs supplied by false lumen, we should inform the primary physician about it to interfere and correct this situation. So the causes may be trauma, hypertension, idiopathic, sometimes connective tissue disease, also aortic aneurysm. Patients usually come with sudden onset of chest pain radiating between the shoulder blades, mimic the MI sometimes. We have a different type of aortic dissection, classification regarding the aortic dissection. We have Stanford and we have DeBakey. We usually using Stanford in daily practice. So type 1 and Stanford representing involvement of the ascending aorta with or without involvement of the arch, and this is treated surgically. Type B, once it is involving the ascending thoracic aorta, and this is treated by conservation, unless there is organ damage or progressive aneurysmal dilatation or uncontrolled chest pain. So this is the DeBakey classification. We have three types. Type 1, once it is involving the ascending and descending. Type 2, once it's involving the ascending. And type 3 once it is involving the descent. So damaging features of aortic dissection, there is antimal flap, and it is representing linear hypodensity that divided the aorta into two parts, false and true lumen. There is sometimes having dilatation of the aorta, not common to see due to aortic insufficiency, and we have also Mercedes-Benz sign. So Mercedes-Benz sign, it is more in the abdominal aorta dissection rather than thoracic dissection. So this is a case of aortic dissection, shows a linear hypodensity that representing antimal flap that divided the aortic arch into the true and false lumen. And this is another case, shows antimal flap, again, linear hypodensity divided the descending thoracic aorta into the true and false lumen. So as I said, you should know which one is the false, which one is the true, and this is a way to differentiate between the false and true lumen. We have very big sign, and this is representing false lumen, and we have this small as the true lumen. So this is a Mercedes-Benz sign and representing two false lumen and one true lumen, and you can see here the right renal artery arising from the false lumen. So we'll move on to the TB. So the TB is airborne infection and is transmitted from person to person through the droplets. What's important in TB and radiology, we have primary TB and reactive TB. Primary TB is a droplets infect the alveolar macrophages, then after 1 to 2 years become active. Reactive is once the immune system is controlling the TB, there is a chance to be reactivated. So this is called reactive TB. And primary TB have appearance different from reactive TB. The clinical features, patient may become with cough, hemoptysis, weight loss, fatigue, fever, night sweats. Damaging features we have in the primary TB, consolidation, not cavitating consolidation. Cavitating consolidation is related to reactive TB. Pleural effusion, usually unilateral, and lymph nodes, but the appearance of lymph nodes, it will be low density, I mean necrotic, with the peripheral rim enhancement. This is regarding the primary TB. Regarding the reactive TB or post-primary TB, patients come with a cavitating consolidation, and usually in the upper lobe. Also, there is a pattern called medullary TB, and this is representing a central lobial nodule and tree and bud appearance. So this is a different cases of TB. So this is first one. This is a 22 years old woman with TB, shows multiple enlarged lymph nodes, mediastinal lymph node, and you can see it is appear low attenuated in the central, and at the periphery there is a wall shows hyper enhanced. So this is called necrotic lymph nodes. Usually it is due to TB rather than malignancy, rather than sarcoidosis, rather than lymphoma. The second case, this is a 37 years old man with acute myeloid leukemia, also TB, shows consolidation in the left upper lobe with adjacent small ground glass density. So again, like I said, the consolidation could be TB, could be malignancy, could be a pneumonia. So the physician should follow the patient with multiple X-ray to make sure the patient has good response to the treatment. If the patient doesn't show any response, so physician should think about lung malignancy. Last one is 27 years old man with bilateral central tiny nodule. You can see this pattern is randomly distributed. So this is related to the medullary TB. Last case in TB. So this is a coronal CT of the chest lung window, shows multiple cavitary lesion in the right upper lobe with bilateral tiny central lobular nodule with linear branching. It's appear as tree and bud. So this is a reactive TB. We will move on to the last topic, pneumonia. So it is acute infection of lung parenchyma, and what is important of pneumonia and radiology, the community, and the hospital-acquired pneumonia. So the community-acquired pneumonia, once pneumonia diagnosed in outpatient settings or within 48 hours of hospital admission, and the most common cause is Streptococcus pneumonia. What about hospital-acquired pneumonia? Occurs within more than 48 hours after hospital admission, and the most common cause is the Klebsiella pneumonia and Staph aureus. CT findings in pneumonia have different patterns. Again, clinical scenario and history of the patient and clinical examination is important. So it comes sometimes as consolidation with air bronchogram, sometimes come as patchy consolidation around the bronchovascular bundle, so it's called bronchopneumonia, and I have case to show. Comes sometimes as cavitation and mimic TB, also branching and tree and bud opacity. Also, as aspiration pneumonia when it is involved bilateral lower lobe. So you always, in cases of aspiration pneumonia, you always check trachea if there is any secretion. Also the main right and left bronchus. So this is a multiple cases of pneumonia. So first picture, this is axial CT of the chest, shows a right upper lobe consolidation with air bronchogram. This is a classic for pneumonia. This is air bronchogram. This is a classic for pneumonia. Second picture, you can see this is a bronchiole passing with adjacent ground glass consolidation and ground glass density that representing bronchopneumonia, as I said. Once it is adjacent to the bronchus or bronchovascular bundles, so it's called bronchopneumonia. Lastly, this is a three-bud appearance in MIB view. So it could be TB, could be pneumonia. Again, follow-up the patient is important, and also for workup. That's it. This is my references. I hope you enjoy the session. If anyone have any question, please write it down.